Okay, good evening everyone. I'm Dr. Abhijit Risal. So as we are here to start the Ocular Oncology session, so I welcome everyone. So we can start with the first paper, Dr. Chandana Kakati. So she is going to present on the profile of surgical cases attending minor operation theatre in a tertiary care center. Dr. Chandana Kakati.
Good evening, everyone. Today, I'll present a paper on the profile of surgical cases attending minor operation theatre in a tertiary care center. Now, to introduce, we all know that ocular morbidity are usually caused by both visual and non-visual pathology. According to WHO, as on 2020, there will be 230 million people who will be visually impaired. Majority will be caused by cataract and undercataract visual error. That already most of us know. But when I search data for the morbidity regarding non-visual ocular morbidity, as there is always primary focus on the cataract, we often miss non-visual ocular morbidity. So what I want to do is that we wanted to do a study with the aim that we wanted to, evaluate the epidemiological and clinical profile of minor operation cases attending a tertiary care center. It was a hospital-based retrospective study. After taking ethical committee clearance, the epidemiological and clinical profile of the cases attending minor operation theatre of AIOC2024 are evaluated in relation to age, sex, anatomical site, the type of surgery performed, etc.
Yes? Chandra, I think we just have some technical issues.
Okay.
And the judges, they are not able to see the presentation. Can you hold on for a minute?
Yeah, sure. Not much done already.
Now you can start.
Can I repeat?
Now you can start.
No, I can repeat or I'll continue.
No. Carry on.
Okay. So after taking ethical committee clearance, the epidemiological and clinical profile of cases were recorded in relation to age, sex, anatomical sites, types of surgery performed, etc. Our study period was from 1st January 2018 to 31st December 2022. The minority procedures are usually defined as procedures that are superficial, limited operative field, and a minimal access intervention. Now I think this, okay. Now coming to our result, the duration of the study was 5 years and total case was 3037. Male-female ratio was slightly, male was more and age range was 2 to 79 years. Now when I see the anatomical side, the most common side was eyelid or eyelash, then was nasolacrimal system, conjunctiva, anterior segment and whole globe. Now, if we see, most of the cases were DCT followed by DCR, then corneal tear, pterygium, collagen, lead repair, excision biopsy, tarsorrhaphy, evisceration, and entropion. Now, when we see the lead cases, it's considered 36.3% cases. Out of this, the most common was collagen, then lead repair, excision biopsy, tarsorrhaphy, entropion, and ectropion. There were 12.7% conjunctival cases, most of which was pterygium, some were excision biopsy, and some were others. Then nasolacrimal system had 32.4% cases, most was DCT, which was slightly larger than DCR. Then the globe involvement was 5.7% cases, and most cases were evisceration. There was sclerocorneal tear in 13.3% cases, majority in the adult with a 73.6% incident, and excision biopsy cases were 8.4%, and the result of excision biopsy were most of the cases it was benign and calculated others, then followed by granuloma, then different tumors which were benign and non-benign as well. Now, in our study, the most common side is eyelash, as I have already said, which was followed by nasolacrimal system, anterior segment, conjunctiva, and whole globe. The most common surgery was DCT, which was followed by DCR, sclerocorneal tear, pterygium, collagen, lead repair, excision biopsy, tarsorrhaphy, evisceration, entropion, enucleation, and ectropion. And majority of the cases are done under local anesthesia, but pediatric cases are done under general anesthesia. Now, coming to our discussion, most of cases are based on eyelid followed by ocular adnexia. As minimum access needed in these cases, plus use of local anesthesia, plus high occurrence of lid pathology as well as trauma, this makes these cases major contributor in case load. Now, incidence of nasolacrimal pathology is 7.9%, which was higher in studies found in Dolges et al., etc. Incidence of anterior segment pathology in the form of corneal sclerocorneal tear is 13.3%, which was slightly lower than that of Humphrey et al. Study. Pterygium incident in our study was 10.9%, which was comparable to the study of Sanjay Singh et al. The excision biopsy percentage was 8.4%, which was mostly benign, which was comparable to the study of Gautam et al. Incidence of glow-related surgery is 5.7%, most common is evisceration, which was mostly due to trauma. This collaborates to the study of Osama et al. Now, coming to conclusion, from our study, it is seen these minor cases cause a lot of distress in large number of people. But as we always emphasize on visual impairment, that is mainly cataract, these cases are often missed and underestimated. Now, if we see properly, there is no already established study, and when we search internet, there is no study regarding the incidence and profile of minority cases. But our study now shows that the importance of developing adequate infrastructure and training of young ophthalmologists in oculoplasty procedure so that the patients suffering from these minority cases can avail a better and prompt care in near future. These are my selected references. Thank you.
Thank you, Dr. Chandana. What was your take-home message here? I mean, beyond the fact that for young ophthalmologists, it's probably the first exposure to do ophthalmic surgery. I mean, we all started with doing entropion and ectropions. Beyond that, what else?
See, there are many surgeries, entropion, ectropion, ptosis, collagen, whatever we do, evisceration with ball. Most people do evisceration, but they don't put the implant. And enucleation, etc. Many people are not doing, we are doing enucleation, but how many are actually giving the implants, intraocular ball implants to make the eye mobile? Yes?
I didn't get your last sentence.
No. Suppose all people, if we see properly, when I see my setup, many people are doing evisceration, enucleation. That's fine. But how many are actually doing actual procedure of putting the implant ball to make the eye actually mobile, all the cosmetic part? That's not done.
You're doing that in the minor OT?
Yeah,
the
of course.
Placement of the implants?
See, there are two portions of the minor OT. One is for repair, that is external minor OT where we do infected cases. Another is for implant and all. What I'm saying is that
there are two separate areas.
Yeah, exactly.
Okay.
So all these things has to be learned properly. Ptosis also, everything.
Ptosis also is done in the minor OT?
No. Yes, in minority. Only cataract we are doing in our majority, in our hospital. That infected, not infected. We have two minorities.
Yeah, you said that. And what pediatric cases you do under general anesthesia in the OT, minor OT?
That ptosis and DCR, DCT, and lead repair, lead repair, etc. Everything is collagen is also we have to do under pediatric minority in general anesthesia.
Yes. Okay.
Thank you.
Okay, just one last question.
Sure.
What was the inclusion criteria for considering the case as a minor operating case? And this is a major operating case and this is a minor operating case.
As I have already defined a minor case, if you see my first slide, we have already defined the definition of minor operation cases. Can I go back to my first slide, please? Oh, the Ajahn presentation has already come.
You can say verbally actually.
You can tell us.
Yeah. What we decided is that minority procedures are locally accessible, minimum invasion, and minimal locally infiltration anesthesia. This is the definition of our minority cases.
Okay, because the only, I think that DCR is not a...
Yes, ma'am. No, ma'am.
No, I just want to ask, you have a operating microscope in your minor OT?
Yes, of course, we have one.
You use that and you do?
See, in some cases, definitely in the corneal tear repair, then you color pterygium, etc., then intubation, etc., we use that one. But for the major lead repair cases like RT, etc., we don't need that one.
You do not need?
Need for the lead repair for major RTA cases, for that everything, we don't need in all cases.
What, operating microscope?
Yeah, because...
suppose the lead repair needs a canalicular repair?
No, that is what I'm saying, that depends on the case. It's case-wise. because it's a government setup, and some night we have so much caseload of all repairs, sometimes it's not possible. Only selected cases we put under microscope.
I would like to emphasize that by no stretch of imagination is a ptosis or a DCR surgery considered minor, or a lid repair. I mean, these days we give equal, like equal importance to these kind of cases. It should not be considered as minor, and lid repairs are very, very advanced these days. And this should not be the take-home message at all, that you do ptosis surgery in a minor OT or a DCR or an evisceration with implant. No, according to me, no. That's not the message that you guys should be getting.
No, the thing is that, ma'am, in medical colleges, in government medical college, we have to label it like that. That is why I'm putting it like this.
That's fine, but I'm just saying, I mean, let it not go ahead that, this can be done in a minor OT. No, it can't be done. It's not the correct thing to do.
Okay, ma'am.
Thank you.
Thank you.
Next.
Thank you, Dr. Chandana. So we move on to next talk. It is presented by Dr. Shripurna Ghosh. She is presenting on medial orbital wall swelling, a hidden enigma. Dr. Shripurna Ghosh.
A very good afternoon, everyone. Hope everyone is having a great academic feast here. I will be speaking on the medial orbital wall swelling, a hidden enigma. It is basically a case. I have no financial disclosures. Now, coming to the case history, we had a 50-year-old female who presented with a painless progressive medial orbital swelling since last 2 years. On examination, she had a firm, non-tender, oval-shaped swelling in the medial aspect of the left orbit. Her NLD was patent. So the differential diagnosis which we could think of was a dermoid cyst and lipodermoid, the mucocele, or an ethmoidal mucocele. This is the clinical picture. The swelling was such that it was causing a telecanthus, and it was even causing an orbital compression, globe compression, sorry. On imaging, we can see her well-circumscribed mass, which was non-enhancing. Here is the video.
Progressive medial orbital wall swelling since the last 2 years. It was a firm, non-tender, oval-shaped, smooth surface swelling in the medial aspect of the left orbit. The skin marking was done and incision was placed. Dissection was continued all up to the wall of the swelling. All the walls of the swelling was very carefully dissected out from the surrounding adherent structures. On further medial dissection, there was an inadvertent transection of the medial wall of the swelling, which resulted in extravasation of green mucoid fluid. This fluid was very carefully aspirated and sent for microbiological examination. The medial wall was found to be densely adhered to the sutural line of the medial orbital wall. After aspiration, a drain was placed and the wound was closed. The patient was then put up for nasal endoscopic evaluation. An abnormal cystic protuberance was seen just above the inferior turbinate. On drainage, a green mucoid fluid could be seen to be coming out of the swelling. The histopathology of the cyst wall was consistent with sinusal lining of the ethmoidal sinuses. The patient was doing well post-operatively. This 50-year.
Now, what should we look out for in a case of a medial orbital swelling? the history of recurrent sinusitis, the duration of the disease, if any associated pain is present or not, if any tenderness is present. The consistency of the mass is very important, whether it's firm, hard, or soft. The nasolacrimal duct patency must be checked in all the cases, and any sutural adherence, if present. Thank you.
Yeah, I want to ask, when you saw the imaging showed a definitive mass in the sinus. So why should one have gone externally to explore that? One can as well go for the DNA, and that would have been over then and there.
Ma'am, we don't do DNA in our department. We actually refer it to a ENT
That's what-
surgeon. Yeah, but when I saw the mass, actually I did not suspect it will have a sutural adherence. I was thinking more towards a lipodermal actually. So I
I
thought
think
maybe
you
I
didn't
can excise
understand
it
my
completely.
question. What I'm saying is, the imaging already shows the mass in the sinus. So why should we interfere at all, is my thing.
Yeah, I actually, when I started planning the case, I did not think that, I thought maybe due to the section of the imaging, it's appearing
No,
appearing
it's
from
very
the
clear,
sinus.
it's not in the extracorneal space.
Sorry, sorry. Yeah.
What madam is saying that you have seen a CT scan before doing
I did
surgery,
see,
right?
I did see, huh.
So the planning
The
is
planning could have been better. I wish I should have referred it to an ENT surgeon earlier.
Did you send the patient to an ENT guy?
Yeah, but that was later, after the
Later.
surgery. After
This kind of a picture, it should have been sent to an ENT person right away, and the nasal wala was done later on.
later on, when I did not realize it was an ethmoidal mucocele.
Okay.
You said you aspirated some material
Yes.
and sent it. So what was the results like?
It had staph, as far as I remember, staph.
Okay.
No, I'm sure you did not take this decision on your own, right? Like to open up the case.
No, but I did not consult the ENT specialist before taking up the case. I should have done that.
Yeah, very important, because this is a dangerous area. You could have gotten into more trouble. And well, that is one of the differential diagnosis of a medial canthal swelling. I mean, is it coming from the sinuses? Isn't it? That's the biggest thing we learn over
That's
here,
what
right?
I learned during the surgery.
Yeah,
When
and
the
that's
fluid
what-
pus came out, that's when I
Yes,
realized it's
yes.
beyond my expertise.
Yes. So it's not, everything is not like a dermoid cyst
No,
in
it
these
wasn't,
areas.
yeah.
You have to be careful of the sinuses. If you think it's that, you have to get a ENT, and we do not want to go into the sinuses. We are not very comfortable.
No.
We have no idea what happens there, right? Yeah. Anyone else?
Thank you.
Thank you. Next, Pulava.
Thank you, Dr. Shripurna Ghosh. Now we move to our next talk by Dr. Shriraj Alapati. She's going to present, Dr. Shriraj is going to present on surprise cystic mystery. Dr. Shriraj.
And I request all the speakers to please come in front so that they can move on quickly for the next presentation.
Good evening, everyone. I'm Dr. Sriraj from KMC Mangalore, presenting a case, surprise cystic mystery. So, a 46-year-old female presented with a chief complaint of left eye lower lid swelling since 3 days, which was associated with pain and redness. There was similar history 3 months ago, which relieved on medication. Patient has history of pets at home. There is no history of trauma or eye surgery or dental caries or sinusitis. So, patient went to a local hospital for the same and was started on tablet amoxiclav and tablet levocetirizine. So, patient is status post mastectomy, radiotherapy, chemotherapy for breast carcinoma 1 year ago. There is no history of diabetes or hypertension. On local examination, there was left eye lower lid edema with approximately 2 into 2 centimeters swelling palpated 3 centimeters lateral to the bridge of the nose and 1 centimeter below the lid margin with well-defined margins, which was hard in consistency, mobile, associated with mild tenderness and a local rise of temperature. So on ocular examination, head posture was normal, gaze was orthophoric, and extraocular movements were full and normal in both the eyes. Visual acuity was 6/6 in both the eyes. Anterior segment was normal in the right eye, and in the left eye there was lower lid edema with 2 into 2 centimeter swelling, as mentioned above. Fundus was normal in both the eyes. So Patient was provisionally diagnosed as left-eye preseptal cellulitis and was started on tablet amoxiclav, ranitidine, serratiopeptidase, and diclo for 7 days. On follow-up, despite a reduction in lower lid edema, a distinct mass was felt on palpation, so patient was advised for CT orbit for further evaluation. So this is the CT showing axial view and coronal view. So in the CT orbit, there was left preseptal heterogeneously enhancing soft tissue swelling with enhancing hypodense area in the center seen adjacent to inferior orbital margin, which was suggestive of abscess, query, and or it could be granulomatous infection. So patient underwent left lower lid excisional biopsy under local anesthesia. So on histopathological examination with a 40x magnification, it has shown a thick cuticle with circumferential muscular layer and a surrounding giant cell reaction, which was suggestive of dirophilaria. The first slide was 40x magnification, which shows numerous eosinophils. And the next one is with the 10x magnification, which shows a nodular lymphoid aggregates with germinal center. So this is the post-op pictures of the patient with POD 1 and 1 month follow-up. So moving on to the discussion, domestic and wild mammals as dogs, cats, and foxes are the natural host for dirophilaria and is accidentally transmitted to humans by Culex, Aedes, and Anopheles mosquito bites. 4 species are transmitted to the humans. Dirophilaria immitis, which causes pulmonary lesions, and Dirophilaria repens, tenuis, and utsi, which infects the subcutaneous tissue. So the ocular manifestations of dirophilaria include periorbital, that is lids, orbital, subconjunctival, and intravitreal. So conclusion, this is a rare case of parasite presenting as preseptal cellulitis. A well-defined mass in ophthalmological examination, such presentation should be maybe considered for a biopsy. Thank you. These are my references.
Did you even think of anything else before doing a biopsy on this case, considering her history of breast carcinoma?
Oh yes, sir. That's the
You
reason
did.
we have taken a excisional biopsy. So could be any mets or
No, I think maybe a PET scan or something, like whether it's a Mets or not. I mean, biopsy is not the way to go.
Yes, ma'am.
For if it was, you were lucky that it was not a Mets, but there was nothing clinically to suggest that it is not a Mets.
yes, ma'am.
Of course, except the inflammation, which is neither here nor there, right?
Yes, ma'am.
So what made you think that it is not a Mets, and let's go in and do an excision?
Ma'am, when we
biopsy?
did a CT, it has shown it was like some granulomatous infection. It was with a CT orbit was done.
CT, can you really make out whether it's a granulomatous
No, we
infection?
can't make out, but they have
Can't
given.
really make out, it's a little dicey to touch these patients like that.
Yes, ma'am.
Maybe after a PET scan has been done, and then you go ahead and touch these patients.
Yes, ma'am. Actually, she has a history of similar kinds of 2-3 episodes. Like since 1 year, she's getting preseptal cellulitis. She's using some antibiotic, and it's getting resolved.
That is a pointer in the direction of a parasitic infection, recurrent lid swellings, right?
recurrent,
That is
so-
a pointer towards your diagnosis, but nothing more than that.
Yes, ma'am. Nothing
Right?
more. Yes,
Okay.
I have only one question that you mentioned in your history the patient has recurrent episodes
Yes, ma'am.
before they reported to you. And you also had a trial of amoxicillin clevenaceid. Shouldn't the radiological investigations be done before you proceed with antibiotic trials?
Actually, previously, the 2 episodes she was treated was in a different hospital. So the 3rd episode, she has come here. So we started on antibiotics. After that, we felt like the surrounding edema was resolved, but the mass was distinctly present like a lump there. So then we ordered for a CT. When we talked with the radiologist, they told it could be abscess or it could be some granulomatous infection. They told query. So then we have taken an excisional biopsy and sent for the histopath. Then it turned to be a worm in that.
That is what exactly my question is, that shouldn't we do a radiological investigation before you give a trial of antibiotics, because the patient has already been treated outside?
Yes, we have to do.
No, I think you guys gave the antibiotics first, right?
Yes.
Or is
Oh,
it,
we also has given antibiotics.
it was given outside also?
Outside it was started and we have continued for like 5 more days.
Because sometimes in acute inflammation, this, if you do it CT right away, you may not get a very clear picture. Sometimes we may
Yeah,
wait for
exactly.
some time,
But they have,
like
you
5
see,
days.
already had been treated outside.
No, actually we have done after the preceptal cellulitis has been resolved, inflammation has been resolved, then we have done the
Then
CT.
they went ahead. Because
Not
otherwise the
during that.
picture, you won't get a clear picture,
Clear, yes.
right?
Thank you.
Thank you, Dr. Sriraj. So we move on to next speaker, Dr. Pooja Gule Dagud. I'm sorry for the pronunciation. She will be speaking on orbital lymphangioma, unmasking the hidden threat.
Good evening, everyone. Myself, Pooja. My topic is orbital lymphangioma, unmasking the hidden threat. Introduction: lymphangiomas are a benign tumor of veno-lymphatic system characterized by abnormal endothelial line channels. Commonly presents in early childhood, constitutes 0.3 to 4% of all orbital tumors. Commonly affect head and neck region, nearly 60%, followed by proximal extremities, the buttocks and the trunk. Orbital lymphangioma may link to a non-contiguous intracranial vascular anomalies causing a potential bleeding. Developmental venous anomaly, often symptomatic, present in approximately 20% of patients with cervicofacial venous malformations. This is the case report of 9-year-old boy presented with a recurrent redness in the both eye over the past 1 year. Visual acuity, near vision, color vision is normal. Hertel's exophthalmometry shows right eye mild axial proptosis of 2 mm. Ocular movements are free and full range. Retropulsion was positive. Auscultation, no pulsation or brouillard. Intraocular pressure was within normal range. Slit lamp examination showed mild papillary reaction in the upper palpebral conjunctiva in both eye. Fundus examination and pupillary reaction was unremarkable. This is the CT orbit axial weave shows evidence of ill-defined soft tissue density lesion noted in the intracorneal compartment of the right orbit in the superior-posterior aspect, causing a relative displacement of the right globe anteriorly. Inferior pictures are showing our MRI T2 sagittal shows a lobulated T2 hyperintense lesion noted in the intracorneal as well as extracorneal space of the right orbit. Here is a post-contrast Stephen weighted imaging showing a homogeneous enhancement, and the down picture showing is a MRI brain. Post-contrast showing abnormal linear altered signal intensity noted in the right capsuloganglionic region, showing a linear contrast enhancement, showing a Medusa head appearance. With this, we diagnosed this case as a right eye orbital lymphangioma involving intracorneal and extracorneal space with developmental venous anomaly in the right capsuloganglionic region with allergic conjunctivitis. Clinical course, we managed this patient with observation. Surgery is not recommended as the lesion is non-encapsulated, not causing diminution of vision, no restriction of ocular motility or cosmetic issues. The pediatrician opinion sought for a developmental venous anomaly. Allergic conjunctivitis is treated with a loteprednol 0.5% eye drops 4 times daily. During follow-up over 1 year, there is 2 episodes of acute proptosis coinciding with the upper respiratory tract infection over 1 year follow-up. But there is absence of significant changes warranting surgical intervention over 1 year. Discussion: Orbital lymphangiomas may cause intermittent proptosis, ptosis, restricted ocular motility, and compressive optic neuropathy. The causes for intermittent proptosis are orbital varices, hemangioma, lymphangioma, recurrent emphysis, recurrent ethmoiditis, periodic orbital edema. The intracranial vascular anomalies present in more than two-thirds of patients with orbital lymphatic malformations. DVA per se are benign asymptomatic. In 13 to 40% of cases, DVAs are associated with cavernous malformations. Hemorrhages cases are most often attributed to DVA associated with cavernous malformation. There are syndrome which will have intracranial as well as intraorbital vascular anomalies are Weber-Masson and Sturge-Weber syndrome. The case can be diagnosed by a clinical examination, radiological analysis, and histopathological studies. Diagnostic specificity of radiological analysis is 77%. Treatment options are patients without threatening vision can be treated with oral corticosteroids. Patient with threatening vision with aspiration of blood, intralesional injection of sclerosing, appropriate drainage to maintain a continuous negative pressure. And organized hematoma is treated with partial resection. Conclusion, orbital lymphangioma should be considered in any case of proptosis in the childhood. Though the management in this case is largely conservative, timely diagnosis is of utmost importance to impart adequate knowledge about the complication associated with it to the parents. And there are red flag signs which are acute painful proptosis, visual acuity changes, restriction of eye movements, diplopia, signs of exposure keratopathy, headache, neurological deficits, and seizures. All these are explained to the parents. And close follow-up and timely re-imaging with a correct clinical decision will improve the morbidity of the disease. This case highlights the importance of individualized treatment strategy for orbital lymphangioma and emphasizes the significance of vigilance even in the absence of typical clinical signs or symptoms. Thank you.
Why did you present this case?
It is a rare case, ma'am.
It's a
It
rare
is a rare
case.
case,
And
I want to tell the observation is important and early diagnosis before intralesional bleeding.
okay. And when the acute proptosis occurred, what did you do to manage the case?
We checked for visual acuity, intraocular pressure, extraocular motility, all that, ma'am. All that was normal, so there was no optic nerve compression as such, so we just followed up the patient.
And it went down on its own?
Yes,
and it
ma'am.
improved on its own, right?
Yes, ma'am.
Okay. No, because these can be potentially threatening. Also, if you get a sudden bleed, you're going to get an acute proptosis which needs to be managed. It's not that you can sit with lymphangiomas. You have to be ready to face these emergencies, right?
Yes.
Anybody else? Questions?
Thank you.
Thank you.
Thank you, Dr. Pooja. Just a kind note, you have exceeded your time. Okay. So we move on to the next speaker, Dr. Vijay Gangavarapu. He will be speaking on pansinusitis, presenting as unilateral orbital cellulitis, a case report.
Good afternoon all. Good afternoon, dignitaries on the dais. So the topic of presentation is already read about. So introduction, sinusitis and orbital cellulitis are most commonly encountered clinical conditions in the practice with overlapping symptoms, making an accurate diagnosis crucial for appropriate management. Up to 86 to 98% of orbital cellulitis cases have a coexisting rhinosinusitis. It is mostly seen in young children of 5 to 15 years age. The most common organisms in bacteria, that is Staph aureus and Streptococci. In fungal, mostly Mucor and Aspergillus, and in helminth, it can be hydatid cyst. The presence of ophthalmoplegia, pain with eye movements, and presence or absence of proptosis is the most distinguishing feature of orbital cellulitis. So here, we present a unique clinical scenario of a patient young boy with pansinusitis whose initial presentation mimicked unilateral orbital cellulitis. So a 14-year-old male was referred to an ophthalmology OPD from ENT department for query left eye orbital cellulitis with chief complaints of left eye diplopia, protrusion of eyeball with lid swelling, redness, pain on movements of eye, and pain in the maxillary region, which was insidious in onset, gradually progressive, dull aching, and present throughout the day with fever. All were seen since 1 week. On examination, a tenderness was noted on the left orbit with restricted eye movements, eccentric proptosis, and ophthalmoplegia with diplopia, chemosis, swelling of upper and lower eyelids. On ocular examination, right eye was normal. The left eye, the visual acuity was reduced 6/9, and color vision was reduced 34/36 slides. The globe was intact with 10 degrees of exotropia and eccentric proptosis. On head tilt, it was 25 mm. Orbital margins were intact. Eyelids, they had upper and lower lid swelling. There was mild lag of ophthalmosis. Conjunctiva had chemosis. The cornea was normal. There was corneal sensations were intact. AC was normal. The pupil had grade 1 RAPD changes. Lens was clear. Extraocular muscles, there is restricted mobility of grade -2 in all cases. Digital IOP was hard. On fundal examination, the right eye was normal, and the left eye, we had mild hyperemia of the disc without any peripapillary hemorrhages. The left eye had FR dull, foveal reflex was dull. Investigations, blood investigations, CBC, we had hemoglobin of 10 gram per deciliter, and WBC, mild leukocytosis was seen. Other blood parameters, serology was negative. He was ruled out of type 1 diabetes and type 2 diabetes. Thyroid profile was normal. LFT, RFT was normal. ECG was normal. Urine examinations were normal. CT orbit, they showed suggestive of left orbital subperiosteal abscess. CT PNS, there was mild pansinusitis. MRA orbit showed signs of optic neuritis and pansinusitis. On culture and sensitivity, there was methicillin-resistant Staph aureus was identified, which was sensitive to vancomycin, linezolid, meropenem, and minocycline. Here we see the left eye pansinusitis, which was also seen as subperiosteal abscess. There was a laterally displaced optic nerve, and the orbital subperiosteal abscess was compressing on the extraocular muscles, causing optic neuritis also. The treatment was, he was started on intravenous vancomycin, ceftriaxone, and metronidazole. Surgery was done because of progressive worsening of symptoms. Emergency septoplasty with FES with left orbital decompression was done. The visual acuity progressively improved, and in post-op day 14 of MRI was done, and there was a marked reduction in subperiosteal abscess. There is complete resolution of pansinusitis. Discussion, the clinical presentation helps in promptly recognizing cerebral orbital cellulitis. Diagnosis and investigations like CT and MRI are most important. In management studies, early intervention by antibiotic therapy is most crucial. In periodic considerations, a high index of suspicion helps in better early resolving of the patient complaints. And prognosis and follow-up is also very important in this case. Last, the conclusion is that early recognition, prompt diagnosis, and timely intervention of orbital cellulitis is most important in pediatric patients, and it always needs a multidisciplinary approach involving ophthalmologists, ENT specialists, ID specialists, and pediatricians. So this was the first day 1 picture. After post-surgery, he had mild subconjunctival hemorrhage, and after 2 months follow-up, the child was totally resolved of all the complaints. Thank you.
How did he land up in the ENT department?
Ma'am, he was a known case of chronic sinusitis.
Okay. Because if you see in the picture, there's some swelling of the lateral wall of the nose also.
Yes, ma'am. Actually, they suspected there might be mucormycosis. So they sent for us for the opinion of ophthalmology to rule out mucor. But instantly, we found out that it was actually, after investigations, it was not mucor as such. They were planning for a treatment of amphotericin.
Okay.
How common is mucor in small?
Yes, ma'am. In our area, they were thinking the child is debilitated state. He was maybe because of his thin build, he might have been immunocompromised. And in our area, there is some higher chances of mucor relatively, but not in this young case.
How many cases have you seen, like in small children, mucor?
Ma'am.
There was so much of mucor in the COVID, post-COVID
Yes, ma'am.
era.
But only 1 or 2, ma'am, not many. That too, they were already having type 1 diabetes, pre-existing immunocompromising state they had. Those children, what I've seen, they were already immunocompromised, not this child.
And the septoplasty and orbital decompression were done in one sitting?
Yes, ma'am. By the ENT, endonasal approach was done, ma'am.
They did the orbital decompression.
Yes, ma'am. What they did is they did ensenectomy. First they did FES because it had a DNS, and then they went up. Ensenectomy was done, and then they lifted the laminar papillae just to create an opening for the drainage.
So all of the treatment was done by the ENT people.
Yes, ma'am. But initial treatment, we started with all the antibiotics, ma'am. So first they advised to rule out mucormycosis. They asked an opinion for the antibiotic treatment also. So what we started on ceftriaxone. Then we said that this was not mucor as such. And then after B scan and all, we ruled out that it might go towards orbital cellulitis.
What made them think it could be mucor? I mean, there was nothing to suggest that it is mucor.
Yes, ma'am. They were saying that the patient had chronic, they were thinking it was chronic
fungal sinusitis
yes, ma'am.
of any kind. Like mucormycosis is something very specific subset which comes
And
out.
since it was unilateral also, they were going more towards that. And the patient was very thin built.
Very?
Thin built, ma'am. The child was a bit weak.
My contention would be it is a very, very expected common case.
Yes.
Yes, ma'am.
It's very much expected. Pansinusitis will present like this. It's nothing uncommon.
Okay.
In fact, children or whatever, patients come in with orbital cellulitis and the investigation is a CT or whatever, an MRI, and it leads you, most commonly you get sinusitis. Ethmoiditis is one very common cause, and you have to keep the ENT people. Usually most of the orbital cellulitis gets referred to ENT people for this.
Ma'am, the other case was the patient also had RAPD changes also, and also ophthalmoplegia.
Yes.
So they wanted to know post-operative prognosis of the patient, how it would be.
You can get PL negative also, you can have it. But then this could have been started by the ENT people also, what you guys did, right?
Yes, ma'am, but they were not sure. They didn't want to put the young boy for the loss of vision, complications of that.
Theek.
Thank you, ma'am.
Thank you.
Good.
Thank you, Dr. Vijay. We move on to next speaker. She is Dr. Ishan Goyal. He'll be presenting on a rare case of idiopathic orbital inflammatory syndrome with late response to steroid treatment.
Good evening, everyone. Thank you, AIOC, for this opportunity. My case is a rare case of idiopathic orbital inflammatory syndrome with late response to steroid treatment. Orbital pseudotumor, also known as idiopathic orbital inflammatory syndrome, is a benign non-infective inflammatory condition of the orbit without identifiable local or systemic causes. It's a diagnosis of exclusion with directed exclusions towards neoplasms, infections, and systemic disorders. It is the clinical history and clinical evaluation are the mainstay of the diagnosis, and orbital MRI is the main important diagnostic test. In our case, a 54-year-old farmer presented with bulging of right eye since 2 to 2.5 months. The proptosis was painful. The pain was dull at rest and sharp on eye movements, and more so looking towards the right side. The restriction of movement on the right side was associated with diplopia, more on the right lateral gaze. The patient went to an ophthalmologist elsewhere and was prescribed tablet acetazolamide SRBD for 20 days and timolol eye drops but the patient did not improve symptomatically. The patient was a known case of diabetes since 10 years. There was no documented history of being COVID positive and no features in the history suggestive of any mucormycosis. On inspection of the proptosis, a unilateral axial proptosis was seen with Navziger sign positive and periorbital fullness. On palpation, the skin over the lid was normal. The skin was pinchable over the lid. There was no evidence of raised temperature locally or tenderness or pulsation thrill. There was resistance to retropulsion felt in right eye. Exophthalmometry by ruler method showed right eye axial proptosis of around 4 mm. On extraocular movement examination, partial restriction of movements in all gazes of right eye was seen with maximum restriction on abduction. Diplopia charting showed maximum separation in right lateral gaze. On ocular examination, facial asymmetry was noted with periorbital fullness on the right side. The vision was, the best corrected visual acuity was 6 by 12 parts in right eye and 6/9 in the left eye. This was owing to the cataract itself, cataract in the eye. Conjunctiva was chemosed and congestion was there, and the lid edema was noted. Blood investigations on admission showed raised CRP levels of 6.8 and ESR of 40 mm at the end of 1 hour. The thyroid profile was within normal limits. Blood investigations were repeated after 1 week, where CRP levels were reduced to 3.2 and ESR reduced to 22 mm at the end of 1 hour. ENT reference was done and DNA was done to rule out sinus involvement, any eschar formation, and any mucormycosis. It was unremarkable within normal limits. MRI finding, the patient presented with an MRI done from elsewhere. On admission, the patient which had an MRI showed features concerning for right orbital pseudotumor. The possibility of cellulitis was less likely. As in our case, the patient did not respond to the treatment treatment. MRI was repeated after 1 week. Same, almost similar picture was seen. Inflamed, bulky extraocular muscles were seen, and preseptal compartment with protrusion of right orbit. Possibility of pseudotumor was noted. These are the orbital images showing right eye bulky extraocular muscles. The patient was put on systemic steroids, that is IV methylprednisolone 250 mg QID for 3 days along with broad spectrum antibiotics, and timolol eye drops were started. Patient did not show response to steroid therapy initially. Patient was shifted to oral steroids after 3 days and tapered over a 6-week period under close follow-up. After 2 weeks, the patient spontaneously responded to the treatment with reduction in proptosis from 19 mm to 16 mm and reduction in lid edema, conjunctival chemosis, and improvement of ocular motility. Examination after 8 weeks showed reduction to 16 mm proptosis. The patient is presently in remission. It is a rare condition that poses diagnostic challenges. The most common signs include eye pain, eyelid swelling, and proptosis. Around 75% of the patients have a remarkable improvement after 24 to 48 hours, such that it is called a diagnostic response to steroids. Although most cases have rapid and dramatic response, there is a chronic form with progressive fibrosis associated with mild or poor response. Orbital MRI says the mainstay of the treatment, while biopsy is usually not performed at presentation. And however, in chronic forms, the patient might show delayed response or mild response to steroids. There are alternative modalities that can be used, like radiotherapy, use of chemotherapeutic agents like cyclophosphamide, methotrexate, and cyclosporine. These are my references. Thank you.
Why did you repeat MRI in 1 week?
Sir, actually, what in our practice, what we say is it will show a diagnostic response to generally to steroids. But even after IV methylprednisolone, that is considered to be a stronger IV set of steroids, it had no reduction in the proptosis, chemosis, and the intraocular pressure. So we were concerned whether we are on the right track or not. And the MRI was done outside, not in our setup. So we wanted to repeat and see if we are missing any septic etiology or anything like what of significance, any mass is there. So we got it repeated from our setup in the in-hospital radiologist and with the reporting done again. So that is why we wanted to know. But since it was similar picture, so we continued with the treatment with oral antibiotics after 2 weeks, which is generally very late for a pseudotumor. We got the response.
You gave the IV methylprednisolone QID.
250 mg, either 1 gram.
You don't give it 1 gram in an infusion drip or something?
Just because it was done in medicine reference, ma'am, because he was a diabetic, they with 1 gram.
They wanted to give it this way.
Yes, yes.
And how many months has it been after he's been in remission?
Now he is around, this is a case, 8-9 months old case, ma'am. So now he is fine, ma'am. He is on a regular follow-up around once in 2 months he comes.
And what will you do if it happens again?
Ma'am, similar steroids.
Similar steroids? Yes. And what if it comes back again? Because this is the biggest problem of
yes,
inflammatory these syndromes, right?
Yes, yes.
So you have to have a strategy. ये एक बार में तो बच गया. इसके बाद?
Steroids.
It's not. I mean, like steroids is not the answer.
Yes,
so you have to have a careful strategy, because ultimately you might have to do a biopsy also. You have to consider it, right? And because it's the first episode, maybe you're lucky it may not happen again. But recurrences are quite often in these cases.
And it is, if it is not recurring, we don't say that it is an intraorbital orbital inflammatory disease. So you have to rule out, even if it is like IgG4 disease, so you have to do serum IgG levels.
Systemic workup.
Systemic workup is very important.
Okay.
Thank you so much. Thank you so much.
Okay, thank you, Dr. Ishan. So we move on to our last presenter, Dr. Vaishnavi Patil. She'll be speaking on magnitude of different lid tumor presenting in a tertiary hospital of North Karnataka. Dr. Vaishnavi.
Good evening all. I am presenting my work on magnitude of different lid tumors presenting in tertiary hospital of North Karnataka. The eyelid is a common area where skin cancer occurs, constituting 5 to 10% of all skin cancers. Most eyelid tumors are benign and constitute 82 to 98% of all eyelid tumors. The majority of the eyelid tumors arise from the epidermis, categorized into epithelial and melanocytic types, with basal cell carcinoma and melanocystic lesions accounting for 85% of the cases. Squamous cell carcinoma and melanoma are rare on the eyelid, with adnexal stromal tumors less frequent. Other tumors include lymphoid tumors, hematomas, and choriostomas. Inflammatory and infectious conditions commonly mimic neoplasms. This is a retrospective study aiming to explore the diverse presentations of lid tumors and to establish correlation between the clinical findings and histopathological features for diagnosis. The study location is Shri B.M. Patil Medical College and Research Center, Vijayapura, North Karnataka. Duration is 3 months from January to March 2023, and sample size is 438. Detailed clinical history was taken and an examination was done. Management strategies including surgical and medical interventions were documented and reviewed. Biopsy reported were analyzed to elucidate the histological characteristics of eyelid tumors and correlated with clinical findings. The results showed mean age of the patients 52.48 plus minus 26.20 years, with 54% being male and 46% being female. The results were as follows. 152 cases had lid warts, 101 cases had chalazion, 79 had lipoma, 56 had cystic lesions, and 22 had sebaceous gland carcinoma, 18 melanocystic tumors, 9 sweat gland tumors, and 1 squamous cell carcinoma. Histopathology and clinical correlation correlated in 182 patients and did not correlate with 43 cases. These are some of the images. First is squamous papilloma, then lipoma, then cyst of mole, followed by pyogenic granuloma adherent to the lid margin, the sebaceous gland carcinoma, and sty. Sebaceous gland carcinoma is seen here, lobulated appearance with increased vascularity and mitotic figures. Second image shows squamous cell carcinoma with keratin pearls. Conclusion: lid tumors have a varied age of presentation with more female preponderance. Lid warts are most common, followed by chalazion in this demography. Sebaceous gland tumors are more common malignancy of lid in the North Karnataka. And histopathological correlation of the excised tumors is of utmost importance for confirming the diagnosis and planning further management. These are my references. Thank you.
I haven't really followed it up. You want to say something? You want to ask something? Again, like, what were you trying to get at with the presentation like this, you know?
Ma'am, most of the medical colleges emphasize on teaching cataract surgery to the students. So with this, we were trying to find out how many patients come for lid swellings and how many of them get treated properly or referred properly. So we just wanted to, with this study, we just wanted to have an overall idea of how many lid tumor patients come and get treated in our hospital.
You know what, like you should focus more on maybe diagnosis here rather than statistics, because all these are well-known facts. So I mean, my advice or whatever you call it to you would be, don't spend time on looking at these. I mean, spend time on looking at how you can diagnose them better. I mean,
Yes,
what are you
ma'am.
really getting at by knowing the number of cases coming? You have to look at that thing. What are you spending your efforts for?
Yes, ma'am.
Which
Ma'am,
though ultimately you have to learn from it.
Yes, ma'am, lesions like warts and chalazion. Chalazion we treated, some were treated with antibiotics, some were treated with intralesional triamcinolone. So those patients were not sent for histopathology or any other.
No, the things which you said are already well known. Like, these are the cancers you get, this is what you get, this is what you get. I mean, what I'm trying to say, why do these things? I don't see any take-home messages from here. She wanted to say something?
No, it's my thing. What I want to say is for all of you. It's okay. I think she can go or you can ask. I just want to tell generally to all of you, see, it is a digital world. it's everywhere around how to prepare a PowerPoint. I found not a single person with 6x6 slide rules. PowerPoint preparation, the way you project, the way you say, and every PowerPoint presentation should end with a take-home message. We hardly found any.
Yes.
Just go through this. It's everywhere around in all your colleges. It should be a practice when you present in your seminars. So that is what is being done in TOT. 4 minutes mein present karna hai. And how you present, how are your PowerPoints is very important. Okay, thank you.
Thank you.
Thank you, everyone.
Okay, thank you everyone. On this behalf, I thank all of them, those who are present here for judging, and we close this session. Thank you. Anybody else to remark anything?
I'm Sabita Katoch. I'm from Himachal, but I work here.
Thank you.
I'm in Oculoplastics, and I do cataracts also, but plasty also I do. Nice meeting you. Yeah, sure.